2 years ago, I came and talked about Curai, and I talked about what we wanted to build. And it was all an idea. I was only talking about, hey, there's all these challenges in healthcare. This is what we want to do. And hopefully, maybe we can do something. Well, here I am 2 years after that to tell you a little bit about what we have done. And I'm just going to really be doing a long introduction to Anitha because she's the one who's going to be talking about the real stuff and the hard science and some of the real research that we're putting into this. But I think it is important for all of you to get a little bit of context about what are we talking about, what is healthcare, how do we scale, how do we get access, how do we improve quality, and what are we talking about. So with that, a few numbers around, what is it that we're trying to solve, right? So over 50% of the world's population has no access to essential healthcare services. We're not even talking high quality, just essential healthcare services. And of course, when you mention a number like this, you can say, well, yeah, that's the other people, right? That's the developing countries, it's not us. Well, in the US, 10% of the adult population doesn't even have a health insurance, and about 30% of the working adults are considered underinsured. And we all know that the healthcare premiums and the insurance costs are going up, and it's going to get worse. As a matter of fact, there are some predictions, as you can see here, that, where's the laser? Okay. Well, you can see on the bottom is there's going to be a shortage. Oh, this is, sorry, I clicked on the wrong button. A shortage of 120,000 physicians by 2030. So, okay, there's more problems, and there's a problem of quality and outcomes, right? And that's not surprising if you think about the fact that an average physician has about 15 minutes to basically recall everything they know about you, everything that is in your history, everything they remember from their medical school, parse all that in, ask you the right questions. That's really important, not forget about what question to ask, and come with a conclusion to a diagnosis and tell you what to do, right? That's impossible. It's like humanly impossible, right? And no wonder that produces a lot of mistakes. And there's about 400,000 deaths a year in the US that are attributed to misdiagnosis, out of which about 30% are directly caused by medical errors, according to some studies. Now, I think that graph on the right about the doctors and their accuracy from Human DX is really interesting. On 1,572 cases that they had, they asked doctors on their platform. These are doctors that are trained and they're performing as doctors to basically diagnose a case, and it was kind of a textbook case that was documented and sent. And the mean individual accuracy for a single doctor, 60%. Okay, so that's very low. There's some caveats to the complexity of the cases there, but still. The good news is if you get consensus between 9 doctors, it goes up to over 85%, which is great. Nobody sees 9 doctors. You're lucky if you see one, right? But if you could aggregate the opinion of 9 doctors, you'd at least be, much better off. And that's a good thing because you can algorithmically do things like that, right? So that's the whole point. What are people doing when they face all of this? Well, they're not trusting anymore, right? First, it's really hard to access healthcare. Second, it's like, I don't even know if I'm going to get the right answer. What do people do? Well, they go to Google. That's what you have, right? You go to Google, you end up in WebMD, and you go into a black hole of like, I think I'm going to die, right? And that's what you got. And there's about 25 million queries a day in Google that are healthcare related, and about 3/4 of the internet users said they looked for healthcare information in the past 12 months, and more than 1/3 admit to having self-diagnosed and say, okay, this is what I got, and this is what I need to take, right? We've all done that. So this is what we're trying to solve, right? And I think we have an opportunity with technology, with AI and machine learning, to solve healthcare. And I think more than an opportunity, I would say we have an obligation, right? We really need to stop optimizing for the next click on the next ad and think about these really important problems. So how do we think, or how do we think at Curai that we can do this? So we envision something like this diagram here, right? We envision a platform in which there's physicians, there's human doctors, but we can scale them through the use of AI. So keeping the doctor in the loop, how do we introduce automation and AI to scale them so they can actually be more efficient and at the same time improve their quality, right? And we want to have less than 20% of the cost for the best healthcare quality possible, not for just a dumbed down version of healthcare, for the best that we can. And also we want this to be available 24/7 and always on. This is what some people call the AI power or learning health systems. There's this notion of, if you look at the diagram, the doctor, when they're making decisions, they're using input from different places, right? They're using internal inputs from the system, like the electronic health records, and they're also using external data, what I mentioned before, what they remember from the textbook they read in medical school, what they are actually Googling on the side while the patient is not looking at them, whatever, right? There's a lot of information that they need to process. I mean, all of that can be automated, right? And we can do that and improve their efficiency, but improve also the quality. So that's pretty much our mission. At Curai, we want to provide the world's best healthcare for everyone. We have a product with hundreds of thousands of users right now. It's a mobile app, and it's providing primary care. We obviously would want to offer all kinds of healthcare, but you've got to start somewhere, and we think that primary care is the gateway to entry of most healthcare problems, so we're focusing on primary care. We have an awesome team, and we're not only doing AI and machine learning. We actually have a lot of physicians in the team, a lot of doctors with different specialties, and we are combining also user experience and product and clinical expertise. I know that many of you might have heard about some of the breakthroughs of AI in healthcare, right? And how deep learning can be used to detect diabetic retinopathy by basically analyzing the eye, or to detect skin cancer also by analyzing some images of skin. And we're not doing this kind of research, but we are doing a lot of research. Actually, I'm really proud to say that since 2 years ago when I came in, and given that we're a small startup, we have already 5 accepted publications. We have the sixth one that has been submitted and hopefully will be accepted next week. And we're working on this notion of like how to solve the problem and trying to use a combination of medical approaches, old school AI, and very state-of-the-art sort of like neural nets, deep learning, and whatnot. Now, a very interesting thing is I can hear June from the presentation this morning saying, oh, this is leading to the uncanny valley. It's like, there's a lot of risk here. And we know, we agree, and that's why we, among other things, we have the doctor in the loop, but also very importantly, and that's what Anitha is going to go into, she's going to talk about many of these publications, but she's also going to go into this notion of like, okay, this work in the lab, like this one and the ones that I presented in the previous slides, it's very nice, but how do you put that in front of patients and doctors, and how do you make it work? How do you put it in the wild? And this is what Anitha, who leads our machine learning research team, is going to take you through in the next few minutes. Thank you. Anitha?
I want to start with this diagram here because that's the foundation of the rest of the talk going to be. So here we have, this is a diagram that Xavier touched upon a couple of slides ago. And I want to set a hypothetical situation right now. Assume that we have removed the physician in this diagram, and you have a patient talking to an automated system. Today, we can do automation. Probably the best way to do is through AI. So for the rest of the talk, automation and AI will be interchangeably used. So going back to this hypothetical situation, so if we had only an AI system working with the patients, now this is a system that's going to make medical decisions for your problem. Everyone in this room will agree that that's not a system that we can sort of, it's a very tall order, and that's not a system we would trust, right? Because I don't think we are ready yet to be able to say that we will replace a physician and use only an AI system. And it's even more important when you think about these systems have to be deployed in the wild. So what do I mean in the wild? It means that the system has to work in environments and situations where it's never been exposed to. Say this model is trained, or if it's a machine-learned automated system, it's trained on, say, 1,000 diseases. And you put that in front of the user. And the patient who comes in has those 1,001th disease that the model has never seen. There's no way it can do anything good there. So we wanted to change and come to a middle ground on how we want to think about these, of putting AI in the wild. We want to assume that there's always going to be a physician that can fall back to, and AI is going to do the automation to the extent that it can really do. Even in that setting, handling in the wild becomes very important. I'll touch upon what the properties of that AI in the wild should be in a minute, but before that, let's dig a little bit deeper into what is the functionality of that AI system should be. So let's imagine this person coming with a chief complaint, say they have a fever and cough. They go into the system. Now, first, a lot of information about that patient needs to be gathered. So is the cough productive? Do you have nasal congestion? Are you having trouble breathing? Right? All of these are questions that you need to ask from the patient and gather information. And once you gather that information, then you need to make an assessment of what the situation is. It could be that you diagnose the patient to have a simple strep throat, and then the plan of action is to just take rest. Or it could be that maybe there is probably a prognosis for a bacterial infection, and so you order a lab for this person so that you can check. And then now we need to follow up with the patients until the patient comes back to a steady state. In fact, I don't think most doctors even check on you to make sure that have you become a normal person again, right after your health condition. So these are the components of what needs to happen between a doctor and a patient. And these are the steps also in which we can do automation. We can automate most of these parts subject to the constraint that there is also going to be a physician in the loop, and these automated pieces should operate in the wild. So let's look at what are the basic building blocks or basic tenets of such a system that you're going to deploy, even if it is going to be supported by the physicians. There is at least two minimal things that it should have. The first is these models or these AI systems should be extensible, which means that it may not know everything to begin with, but it should have the capability to learn. So some sort of a never-ending learning loop where it can iteratively learn from the physician or from some additional data that it may get access to. The second part is that it should know what it does not know. I mean, the important tenet of actually putting something in the wild is that it needs to know what it doesn't or what it does know. Right? So if it does know something, it can go on to make it automated. If it doesn't know, it should know to at least gracefully fall back to the physician so that the physician is the one who's taking charge of that situation. AI models that do not build any of these into them are not useful to be put in front of the users. So in the rest of this talk, for majority of the part, I'll talk about one particular automation, the diagnosis, and I'll walk you through some of the work that we have done at Curai to sort of how to build in these two properties into the system. The notion of having physicians be assisted by an AI system is not new. It's there been since the 70s. The very first system that came into being is the Mycene system from the 1983 or something like that from Stanford that looked at modeling only infectious diseases. It could be as assistive for doctors when they're dealing with infectious diseases. So systems like DXplain from MGH covers about 1,000 diseases and about 3,500 findings, which are basically symptoms. And they're probably in the world the most comprehensive set of diagnosis models you could ever have. And remember, these expert systems are nothing but old school AI systems where they have a knowledge base, which is based on curation using evidence-based literature by a large number of doctors, and an inference algorithm that works on top of that knowledge base. So there's 30 years of work that has gone into the system. And so now you can say, oh, that has 1,000 diseases. Can you deploy that in front of the users directly? Or even or can you use it to help the physicians? The answer is, these are not systems that are really ready yet to be put in front of the wild. First, because they don't satisfy these properties effectively. First, are they easy to extend? Not really. So we know about Zika virus that came up recently. So it's not going to be in these expert systems for a very long time until there's been enough literature being done, evidence-based literature that says that, OK, Zika virus, the symptoms for these are cough and cold and pain and travel to tropical countries. Joint pain. So until those has been experimentally studied and vetted across a large population, these cannot even be considered to be put in the expert system. So it takes a long time for this model to add a new disease to these expert systems. Second, it doesn't know what it does not know. So in this example that I just told you about Zika virus, so it can look at your joint pain and fever and cough and maybe predict it to be like a normal flu. But really, the important symptom or important thing that the person recently traveled to a tropical country is such an important signal that it misses, and it will just say, oh, this must be a flu. And now think about this. This is going to be a huge misdiagnosis that has been done to this patient. And it's going to be a very hard cost to recover from this diagnosis. So now I just told you that maybe expert systems are not ready to be put in the wild, but that doesn't mean that they are not useful. So I'll tell you how we could use them in a bit. But first, I'm going to walk you through some of the research we have done in these two contexts of assisted diagnosis in the wild. These are research papers that we have published either at Machine Learning for Healthcare conferences and at NeurIPS workshops on machine learning for healthcare. So the first property that we'll look at is extensibility. Right? How do you extend models? So the easiest way that everyone in this room will agree that if you want to build extensible models is make it a machine learning model. Okay, so now if you want to make it a machine learning model where if you had more data, you could probably be training better models. Now the question is, where do you get data from? Right? Who is going to give you the data to even start with a large number of diseases? And that's where we went into this notion of how can you use those 30 years of knowledge that are encoded in the expert system as a prior to build your initial models. So our hypothesis here is that if you can take that knowledge base and build a clinical case simulator that can be used to simulate clinical cases from these expert systems for every disease, then you have a large collection of data, labeled data to work with. So in this example here, the disease is called is an acute viral hepatitis, and symptoms like anorexia, jaundice, or vomiting that happened recently. There's a bunch of symptoms that you need to have to be able to classify this person to have acute viral hepatitis. Now, using a clinical case simulator operating on that expert systems, you can generate data for every disease that's there in that system. And then once you have this labeled data, this becomes a normal machine learning problem, right? Where you can take your state-of-the-art machine learning algorithms to train a model. Now, this is not so this is great, but then the problem is what happens if you want to extend it? That's very easy. So you could get examples from your EHR that talks about a patient having Zika virus in this case, and those becomes your additional training data that can be added to augment the data. So you don't have to wait for another 10 years until the researchers happen to get Zika virus into the system, but you have a few examples that you can start with, and you can train your model. So this is nice, assuming that you have access to a large amount of training data to begin with. But by design, many diseases are very rare. It depends on the context. So malaria is very rare here. Hypothermia is very rare here. And if you're training on models, and there are some diseases that are rare across the globe for a very, very good reason. So now, but if a patient comes into your system and have some of these diseases, you need a way of being able to identify those diseases. How do you do that? How do you work with very small amount of data? That's another area of work that we did recently, where we borrowed ideas from this low shot learning, where the goal is not to learn a classifier to predict to classify a particular patient's profile into a particular disease, but rather learn representations for these diseases. And then now when a patient comes in, you compare it to that representations. And it's very easy to extend even when you have a small amount of data. Our work where we introduced a model called prototypical clustering networks combines a graphical model, a probabilistic graphical model, with a deep neural net to be able to learn these representations from very small amount of data so that you can do these comparisons. You can do classification on even when you have very small amount of data. I will not be talking about this in the interest of time, but I'll be happy to chat, and both Xavier and we will be happy to chat afterwards regarding this paper. So the second part of this is about knowing what you don't know. So we haven't touched upon that concept yet. And it's a very, very important concept of knowing what you don't know, where we want to be able to where the automated system should be able to fall back to a physician when it's not sure about a particular medical condition. And this is a very common theme, really, because in a primary care setting, there are many diseases that doctors don't diagnose. They instead refer you to a specialty. Let's take a very extreme example of dermatological condition. Say you have a skin problem of abnormal skin growth. Okay? Even though 30% of dermatology conditions are seen in primary care, but if you had an abnormal skin growth, when the doctor sees that, they will immediately recommend you to go and see a specialist, because you want to be able to rule out a malignant neoplasm, like a cancerous growth that is malignant. So, and that's an extreme example, but even in other examples here, where there may be some diseases that you know for sure that's the diseases you want to deal with, and then there are a universe of more diseases that your system or your current system cannot handle or doesn't want to do it, right? So now your model that you're training should be aware of this and be able to avoid misclassifying those unknown diseases as something within the diagnostic scope. So in a recent work that we will be presenting at NeurEP's workshop this December, we posed this problem of open set medical diagnosis, where we assume that there is a small amount of data which are not labeled, but these are examples of cases that you may see in your doctor's office, but you will always recommend to a specialty or ask them to go somewhere else, right? So you have some of these examples, and those becomes your out of distribution, if you will. And then we can now model, you can come up with a classification model that makes sure that you're doing very accurately on the diseases that you care about and has a very high entropy on diseases that is not something that you can deal with, so that you can just fall back to the physician and they make the decision for you. Okay, and there are many ways of doing this, and we tackled it in a particular way. You can also think of it as a Bayesian model where you can do Bayesian inference on this. So going back to the desired properties of AI in the world, we want these to be extensible and know what doesn't know, but this is not something that's restricted to only diagnosis. In any part of the system, you could do it. So for instance, when you're gathering information from the patients, the patient may come and present themselves with situations or medical conditions that the system does not know. Then you should be able to go back and to have the physician gather that information. So in this work, again, we'll present at NeurEP's this December. We talked about how to make sure that you can automate only the amount of information you could automate and then fall back to the physician by saying that we are trading flexibility for control. So we know when to automate and when not to automate. And how effectively can you automate? Right on time. So looking forward, what we think is that you want to always have this middle framework of saying we want to put AI in between the patient and the doctor, but at the same time make sure that these AI systems can operate in the wild. Right? And the basic premise of all these work should be about making sure that it's extensible and it does know what it doesn't know, so that we can actually be able to provide quality and much better care with in a very cost-effective way to everyone. So we don't have to have those 30% of the non-insurance not being able to go to the doctor. We should have everyone in the world to be able to have access to healthcare. And healthcare is a birthright, I mean. So, and at Curai, that's something that we are very passionate about. And if this is a space that really interests you, would love to chat with you. Thank you so much.